Okay, then I'm going to give a very brief presentation of some data that we have on the topic of viral community-acquired pneumonia. And this, just as an introduction, this is a patient in March when we started with the pandemic that we knew this was the first cases in Louisville. We knew that the patient has COVID because two family members from the same family group were admitted with COVID pneumonia. But then when the first nasopharyngeal swab was negative, we repeated next day. And then the same day, the sputum was positive. And we know that this happened with all the viruses. For us was news at that moment because this was the beginning of the pandemic. That is also happened with SARS-CoV-2. And we know this, this is a meta-analysis that we did a couple of years ago that we're looking at in all the studies with nasopharyngeal swab or oropharyngeal swab, the incidence of viral pneumonia was around 25%. But in the few studies that have looked at lower respiratory tract, you look at these few studies, then the incidence was 44%. Of course, these are different studies, different populations, different sites that we cannot compare. But there's always this concept that if you look at the lower respiratory tract with viral pneumonia, you may get better diagnostic capability compared with the upper respiratory tract. Why this happened? There's always the possibility that we obtaining nasopharyngeal swab is difficult, and it may be a sample, poor quality. There's the concept that the timing of the not viral pneumonia, but the time that the patient arrived to the hospital from the upper respiratory tract, the virus may move to the lower respiratory tract, or even the consideration that some patients may have inhalation viral pneumonia and the upper respiratory tract may not be as important. This was the explanation that we have for this phenomenon. Then what we have here is what we did a prospective study of adult patients, 18 years, admitted to different hospitals in Louisville. The patient needs to have acute respiratory signs and symptoms. We need to get a sputum production to be able to get sputum. There was an inclusion criteria and a new pulmonary infiltrate. Then the patient qualified for our standard community-acquired pneumonia patient hospitalized, and then informed consent, and we obtained the upper and lower respiratory tract samples. The samples were a nasopharyngeal swab. The oropharynx, we decided to get saliva. We know that saliva has been now detected with SARS-CoV-2 and is becoming an important sample. And then, as we mentioned, everybody has a sputum. Then we have the sputum as a lower respiratory tract sample. Then every patient has PCR with the Luminex, the influenza AB and the RSV. Then essentially we're doing PCR for two viruses, influenza or RSV. And any person with a positive PCR in any sample, then we assume that this was either RSV, community-acquired pneumonia, or influenza, community-acquired pneumonia. Then the results. We have 22 patients that we identified a positive PCR for RSV. Then there were 22 patients with RSV community-acquired pneumonia. When we look at the nasopharyngeal swab, with these are the numbers. We have 13 patients. Then this is the percentage of positivity for all the cases. When we have saliva, we go to 74%. 17 patients were identified by saliva. And when we look at sputum, we have 41, excuse me, no, these numbers are, remember, it's not 41, but it's, yes, it's 22, yes. And it's 51% of the samples. When we look at influenza, 30 patients with influenza, there were only 7 patients that were identified by nasopharyngeal swab. For saliva, 23 patients, 77%, and for sputum, again, 77% of the patients. Then what we found for RSV and influenza, that saliva and sputum are much better samples than the nasopharyngeal swab. That is our gold standard every day for viruses. And then we have a total of 51 patients. We have the two viruses. 51 patients with viral cap, RSV, or influenza. 40% identified by nasopharyngeal swab, 78% by saliva, 84% by sputum. And if we combine saliva and sputum, we have 96%. Then essentially, our summary of this study is that probably we are doing an underdiagnosis, approximately 50% of viral cap, if we are just basing our diagnosis on nasopharyngeal swab. That is our standard approach. If we were to, based on this, we were to select one sample, we would select saliva, but if the patient has a sputum, this would be also the ideal sample to do PCR detection. In the same study, we have patients with the same characteristic, with history of chronic bronchitis or COPD, but with negative chest X-ray. Then these patients were characterized as having an acute exacerbation of chronic bronchitis. Then when we look at these patients with chronic bronchitis, we have 54 patients with chronic bronchitis, with either a positive sample for RSV or influenza. And the number for chronic bronchitis is very similar. We have 50% identified by nasopharyngeal swab. The exacerbation of chronic bronchitis would be viral, 50%. Saliva will be 72%, and sputum will be 83%. And combining the two, saliva and sputum, we have 96%. Then summary is that probably viral lower respiratory tract infection is severely underdiagnosed in our clinical practice. And this morning there was some discussion that probably every bacterial pneumonia is secondary to a viral pneumonia. And probably I will add that, yes, I agree with this. And probably our viral pneumonias, or at least viral lower respiratory tract infection, are severely underdiagnosed with the way that, with the methodology that we use now. And there was another discussion this morning, the presentation of Tom File. He said that we need to identify viruses, because if we have a virus, then if the patient doesn't qualify for a bacterial co-infection, I can discontinue antibiotics. When we want to discontinue antibiotics in viral pneumonia, probably first we need to diagnose better viral pneumonia, because if we want to discontinue antibiotics, we may have more than 50% of the patients that we can identify that we can discontinue antibiotics in 24, 48 hours. And I may say this is the summary. This topic is open for discussion. Oh, thank you. Thank you. Yes. Oh. Yes, just kind of see it here. Wow, yes. Yes.
This is great. Thank you, Julio. You know, we've been talking about this exact question.
We've been talking about this for some time.
I have a question about language and terminology. One of the things that I'm really wondering about is, as we get better at characterizing, you know, using rapid diagnostic tests to identify pathogens, if the speed with which we pick up the diagnosis of viruses outpaces bacteria, when we use the term viral cap, it's very difficult for clinicians who kind of still have a simple model of disease, where it's one offending organism invading some sterile organ, that I'm concerned that if we use viral cap, people think a little bit too linearly, and they assume they have the pathogen. And so how do we use language to be a little bit more precise? I'm wondering if it's not wise to promote the idea of viral cap, because I think it kind of tends to help make clinicians jump to, I've already found a pathogen, and there's this culture of pathogen-directed therapy. And I'm wondering if we should actually try to use language to state it more like cap as a syndrome, where we then detect, you know, different pathogens. Wonder what people think about that.
I agree that the terminology is awful today, because for instance, you know, we have the issue when we selected the question for the guideline. The question is, when you stop antibiotics for viral cap? Well, it's the wrong question because you have viral cap, you don't need antibiotics. You don't need to start. The problem is that we never know when the patient has viral cap because this is why I said initially, this patient has signs and symptoms, respiratory infection, the patient has sputum, and the patient has a pulmonary infiltrate, we call it pneumonia. And if we find a virus, we call it viral pneumonia. But in reality, this patient may not have pneumonia to begin with, and the virus may be the upper respiratory, maybe just bronchitis in all these patients, and the pneumonia is secondary. Then I think that and then probably we need to say that if this patient has viral pneumonia, we can never define if there is co-infection with a bacterial pathogen. Now, it has to be very clearly stated that we don't know for sure. In pneumonia, we never know for sure the etiology. I remember that in the past we used to say, we identify a pathogen, say definitive etiology, presumptive etiology, colonization, and we have all these different ways of categorize. And the idea was that, yes, if you find a pneumococcus, you culture pneumococcus in the sputum. And the gram stain was negative for gram-positive diprococci. It was a presumptive etiology because it may be coming from the oropharynx. If you have white blood cells, pneumococcus inside, then you have definitive. But to do this classification, you need to do gram stains. And see, we don't do gram stains anymore. But I agree with you that these patients, we call it viral pneumonia. Probably the best way to approach this is identification of a virus in the respiratory tract. Then if we want to identify a virus, if the patient has a lower respiratory tract infection, meaning either exacerbation of bronchitis or pneumonia, and you want to identify a virus, ideally you need to get a lower respiratory tract sample. And you don't get a lower respiratory tract sample, since you get the saliva, since you get the mouth is the area with whatever happened, everything ended there. And the other thing is that to get saliva is not a problem. Everybody you can get saliva. To get a nasopharyngeal swab and go there and swab is the sicker the person, the more difficult. And another thing is that with a nasopharyngeal swab, you cannot get more than one sample. Once you get a sample, nobody wants to do this anymore. With saliva, we can get every day to see what happened with the virus. Now, with COVID, the idea was that since COVID seems to be that give you parotitis, you have so much COVID, SARS-CoV-2 in the mouth, that saliva is very good. I don't know these other viruses. There's something in the glands, in the oropharynx, but we were surprised that in saliva, there was always positive PCR. But the sputum is always, again, we have studies, you do bronchoalveolar lavage, you find it there, and maybe negative, but we didn't know that the sputum is going to be, and these are the same day, the same person obtained the sample, the same laboratory, the same PCR. This is, yes.
Yeah, two questions. Just the first one would be if the assumption is correct that every bacterial cup is a follower of a viral infection, then we could not stop antibiotics in any cup with viral infection, which would be a stressful consequence, and we should consider prophylactic antibiotics in a subset of patients maybe. And the other thing is, if you detect viruses in saliva in such a high percentage, did you check saliva in asymptomatic patients for RSV?
No, because this study was a very good point for all these pathogens. As we get more and more into because this was I'm sure that all these viruses are part of the normal flora. The same that the pneumococcus, some patients have pneumococcus in the nasopharynx. I'm sure that all these viruses are going to be part of the normal flora. Now, how common is this? But no, what we were looking, because here this was part of the large study, because the patients have to sign the consent, and we need to get samples on everybody, and then do PCR. Then we have a large number of patients that were negative, that we didn't find anything that we have there on the but for the positive, and this was last winter when there was this, there was a lot of RSV going around, and we were to find so many RSV patients. Then these were patients symptomatic with a pulmonary infiltrate or history of bronchitis. I think that is, if this happened with, we wouldn't have the study with SARS-CoV-2. And I don't know, I couldn't find that this study was done with SARS-CoV-2. But as we get more capability to treat viruses, and it's going to be more antiviral therapy for patients with pneumonia, it's going to be also very important to define who has, quote unquote, a viral pneumonia. And it's going to be, and again, if everybody admitted to the hospital has some form of viral pneumonia and a percentage get the pneumococcus, then the separation to say I stop antibiotics because this is only viral pneumonia without bacterial co-infection, we go back to what we discussed today, the procalcitonin, the CRP, the white blood cell count. What do we have today to say that the urinary antigen say that in 24 hours I feel confident that probably there is no bacterial co-infection. But I get the feeling that RSV, plenty of these respiratory viruses, I'm sure is going to be part of the nasopharynx or some normal people. And then the question is going to be as happy with pneumococcus. You have a pneumococcus that you have the nasopharynx, or happy with a Haemophilus influenza and acute exacerbation of chronic bronchitis. You have your H flu, but to get the exacerbation, you need to get a new H flu, a new serotype. You have the pneumococcus, but to get the pneumonia, you need to acquire a new pneumococcus. Is this happen also with when we're going to study the virome in the lung, and we have all these viruses? I'm sure that some of these viruses are going to be part of the normal flora. There's something happened, and now you develop influenza because the influenza virus start multiplying. It's also interesting to me the data and some animal studies that the bacteria predisposed to a viral infection. Because there was some data indicated that yes, you get the pneumococcus and then you develop influenza. And then at least in the laboratory, I read in some articles of some laboratories that you infect epithelial cells with pneumococcus, they get more prone to be infected with influenza. Then these things, this is a pathway both ways. Then and as we probably all infections are it's a combination of bacteria and viruses until we figure out. Some may be only bacteria, some may be only viruses, and then we have a lot of mix. Any other comments or questions? Great, then we keep moving.